Cerebrovascular Education Series number 5, Right Middle Cerebral Artery Aneurysm Clipping through Mini Pterional Craniotomy. Our gentleman is a 44-year-old man who presented with prior rupture from left middle cerebral artery aneurysm, which was treated with clip ligation. He was found to have right middle cerebral artery aneurysm 3 by 4 millimeter wide neck, and decision was made to treat it surgically at a later date. Angiogram showing the aneurysm. This is wide neck pointed downwards, and you can see the large anterior temporal artery close to the dome of the aneurysm, and also appreciate the small frontal branch, which is a concern in this clipping of the aneurysm to make sure the branch stays patent. We have endovascular options, however, because of the longevity and durability, we decided to do surgery and decided to do mini pterional because of the length of the MCA and distal position of the aneurysm. Here is a mini pterional craniotomy completed, approximately 3 by 3 centimeter in size, and sharp dissection of the arachnoid plane is started to separate temporal and frontal lobes. 1 to 2 small veins crossing from frontal to temporal side can be sacrificed. Because this is a prior ruptured aneurysm, you can see that the arachnoidal adhesions are very um, um, tough, and most of the dissection has to be performed sharply. Here, once again, demonstrating tough arachnoidal adhesions and a combination of blunt and sharp dissection, but mostly sharp dissection to separate the temporal and frontal lobes. As we continue to separate frontal and temporal lobes, we start seeing more of the middle cerebral artery branches. This is an unusual anatomy because of the large anterior temporal branch, and therefore dissection has to be very clear. We are identifying and separating these branches from the surrounding parenchyma, and small perforators are carefully separated. Further sharp dissection is continued, and the large temporal branch is separated from the frontal branch. Because this is a young individual, you will see that the vessels go into spasm very quickly. Thickened arachnoidal adhesions are demonstrated once again, requiring blunt and sharp dissection. As we continue to dissect, we are seeing a second bifurcation, and we are assuming that this is a bifurcation of the large anterior temporal branch. So the dissection is then continued, and we can now start to see some of the plaque in the wall of the aneurysm. And at this point, we still don't have proximal control. Therefore, we decided to separate the frontal and temporal lobe completely. You can see in the depth the deep part of the sphenoid wing and base of anterior clinoid process. Once the frontal and temporal lobe are completely separated, we're trying to identify the origin of this anterior temporal branch and continue to track down until we are able to identify a middle cerebral artery proximal to the aneurysm. Sharp dissection is performed around these arachnoidal adhesions to obtain proximal control. Dissection is completed around this main anterior temporal artery going into the proximal middle cerebral artery. We then focus our attention back to the aneurysm complex and start dissecting through the tough arachnoidal bands and tissue. The branches are carefully separated from each other. The smaller frontal branch is already spasming and kinking. Here is the proximal M2 just before the bifurcation. Now we have a good landing zone for clip, temporary clip if needed. Small branches of the anterior temporal artery are carefully separated, demonstrating once again tough arachnoidal bands that have to be sharply taken down. Once these are taken down, the vessel will be mobilized, and you can see this significant degree of spasm already from manipulation. Now we're dissecting around the aneurysm to confirm that it's separated from the temporal lobe and from the anterior temporal vessel. And once again, all the adhesions are taken down bluntly or sharply. The aneurysm is separated from the temporal lobe and dissected 360 to be able to pass the clip. and to ensure that none of the vessels will be caught in the clip. After complete dissection, we decided to place a sideways clip and try to be in line with bifurcation. Clipping this aneurysm across bifurcation would be dangerous because it will cause spasm of this small frontal branch. You can already see that there is kinking. First of all, we ensure that no other vessel or tissue is caught in the clip. We then use papaverine to help with spasm. After leaving papaverine on for a short period of time, the vessels are now plump and red and pulsating. Microdoppler is used, and then ICG is used to ensure that all vessels are filling briskly. There's a small amount of kinking, but it's acceptable since the pulsations are good and the aneurysm is completely occluded with no filling. Patient did really well. Post-operative angiogram showed complete exclusion from the circulation, and all the vessels were open. A CT scan shows the small 3 centimeter craniotomy. Patient did very well and was discharged post-operative day 1 with no deficits. Thank you.